Hello, my name is Dr. Tom Fishbein, and I'm the Executive Director of the MedStar Georgetown Transplant Institute here in Washington, D.C. We perform hundreds of transplants each year of the kidney, liver, pancreas, small bowel, as well as multi-organ transplants, also all done at one time. These are sometimes called multivisceral transplants. We conduct research to learn more about things like rejection and the best methods of transplant to ensure the most successful outcomes for our patients. We also run educational and training programs about transplantation. All this has led us to have some of the best transplant outcomes currently achieved in the United States or around the world. Today, we're here to focus specifically on kidney transplants and living kidney donation. You can take part in this webcast in a couple of ways. We'll get to your questions in a few minutes, but you can submit them now by going to the chat box feature on your computer screen, typing in your questions, and hitting send. If you're watching us on Facebook, place your question in the comments section. You can also follow the conversation using Twitter using the hashtag AskMedStar. To help us learn more about kidney transplants and living kidney donation, I'm joined by Dr. Matt Cooper, Director of the Kidney and Pancreas Transplantation Program, and Dr. Jennifer Verbisi, Medical Director of our Living Donor Kidney Transplant Program. We also have as special guests here tonight with us, Tina McRae and her sister Rolanda Franklin, both of whom came down from Baltimore. Rolanda donated her kidney to Tina just before Tina was about to start dialysis, which is something we very much like to see. Often, dialysis is not the best answer to kidney disease. Dr. Cooper, there are many people in need of a kidney transplant who are on dialysis as we speak. Why is kidney transplantation preferred over dialysis?
Well, certainly that is a great way to start off this conversation, Tom. I think the challenges that we face when we're seeing new patients, or even when we're out speaking in the community, is there's a misperception that transplant and dialysis are two ways of taking care of the same problem that have similar outcomes. We in transplant and those around the world that study transplant have shown over and over again that the outcomes for people that are transplanted versus those that remain on dialysis are not comparable at all. In fact, the data would show pretty clearly that people that are transplanted, we always say, live longer and live better. In fact, I often tell people that dialysis robs people of years of life, and our job is to try and provide a better answer to end-stage renal disease or to developing end-stage renal disease than dialysis, and that answer always comes to transplant. What's a troubling issue surrounding all of that data when we continue to demonstrate the value of transplantation is that there is a waiting list because the supply of kidneys is much less than the demand of people here in the United States that need them. There's a full 100,000 people here in the United States that are waiting for a kidney transplant. The challenge is that unfortunately the waiting time then means people who are coming to us today for transplant, who are absolutely appropriate candidates for the operation, have been found and have been told that they will live longer and live better with transplant, that most will have to wait about 3 to 5 years for that transplant to happen. For all of those benefits that we say, living longer, living better, it's not so easy. And sometimes those 3 to 5 years are a very challenging time for people on dialysis because we know the problems that often led to their end-stage renal disease, most often those being high blood pressure and diabetes, those continue to be a problem. So we here at MedStar Georgetown Transplant Institute are always in the business of trying to create as many opportunities for people through transplant as possible. We are very aggressive in our transplant program. We make sure that no organ goes wasted that should be transplanted. We make sure that we listen to offers very carefully. We make sure that we're very complete in our evaluations of recipients, wanting to make sure that we provide them with the best opportunity. We want to make people's lives better with transplants, and we think that requires us to be very complete in our evaluations. But again, one of the challenges we face is that we just don't have all the organs waiting to be transplanted for people that come in to us and say that they need them. So one of the biggest things that we try and pioneer and promote at the MedStar Georgetown Transplant Institute is all of the opportunities that are available for potential recipients that have living donors. And we're going to spend, I think, some time talking about that. I think it's one of the most important things that we discuss when we meet new patients is what are the opportunities through living donation. And I think that's where we wish to go when we move forward with potential workup, is being honest about the challenges, being realistic about the supply and demand problem, but trying to have a realistic discussion about what opportunities are available through living donation.
Dr. Verbesi, what are the specific advantages of living kidney donation over cadaveric organs?
Well, living donation definitely has a lot of advantages, and the first thing I like to tell all my patients is if they can find a living donor, the kidney tends to work faster and last longer. Basically, we do a donor and a recipient in side-by-side operating rooms, and so we time it very well so that as soon as the kidney comes out of the donor, we're putting it into the recipient. And there's no question that that very short time helps with the survival and function of the kidney. The second biggest thing is that we reduce the waiting time to almost nothing. So the donor has to come in and be evaluated, but within a couple of weeks we can be doing the transplant. So whereas patients might wait 3 to 5 years for a cadaveric organ, they could wait weeks to get, or even shorter than that sometimes, to get a living donor organ. And that also allows us, as in this case, to sometimes transplant people before they ever start dialysis at all. And this definitely leads to improved outcomes as well. And the third thing I like to mention about living donor is that it helps us provide transplants to patients that are hard or difficult to match. So that some patients who might have had a transplant before, or pregnancies before, or blood transfusions, they may have antibodies in their system that makes them a more difficult match. And when we have a living donor, we know exactly the day we're going to do it. We can plan for that. And we have many procedures now that we do that include things like plasmapheresis and other drugs that we can give that sometimes allow a patient to get an organ from a donor who they otherwise have been told that they're incompatible with. So there's no question that living donor has a lot of advantages, and we really strongly encourage all of our patients to go out and talk to their family and their friends and their community to see if living donor is an option.
Dr. Cooper, can you talk about some of the steps we take to make sure donating a kidney is a safe process for the donor?
Yeah, I think that's a very important question, as safety always has to be our #1 priority, particularly when we're talking about individuals that come forward with the intent to do something good for someone else. We never want to hurt someone who's interested in doing something so kind and altruistic for another individual. We have a very elaborate and multidisciplinary process, meaning we have lots of experts at the MedStar Georgetown Transplant Institute that work together in a collaborative fashion to make sure that everybody with their specific specialty in mind views that donor from both a medical and a psychosocial perspective to make sure that not only is it safe from a medical standpoint for this individual to come forward and to donate the gift of life, but also to be sure that they're comfortable in making the decision, that they don't feel forced or we say coerced to make the decision, that they have support after the procedure is done to help take care of them. And so we meet regularly as a team. I think it's very important to appreciate that the MedStar Georgetown Transplant Institute has been one of the pioneers in transplant around the world. We're celebrating 40 years of doing transplants in the Washington, D.C. area. And I think that's what it speaks to, the fact that we have a history of living donation. We have, I think, the resources to make sure that it's safe for this individual to become a living donor. I never want to look a recipient in the eye, and I never want to look a donor in the eye and say that we've taken risks with someone that you care about or that you have made the sacrifice for someone else. And so we take no shortcuts when it comes to promoting the safety of living donation, and that's because, again, we're in the business of doing good things for good people and making sure that we do it right.
We're fortunate to have with us two sisters, Rolanda Franklin and Tina McRae of Baltimore. Rolanda donated her kidney to Tina. Tina, why were you about to need to start dialysis?
When I was younger, I inherited Alport syndrome from my father. And as I got older, I went to the kidney doctor, and he told me that I had to get on the transplant list. He said he was getting ready. He said, I'm gonna get you ready to start dialysis, like you say, start dialysis. And so I got the fixture. It didn't work, and I went to one hospital. I had no luck. And then, so when I called Georgetown and made the appointment, well, I had the appointment, right? Well, I got a knock on my door. My sister called me before I had the appointment for the evaluation, and she said, I'm coming over your house, and she lived 5 minutes away from me. And I said, okay, all right, what's this about? And she said, sit down. Tell them what you said.
I said, I prayed about it, and I want to see if I'm a match. I said, and even if I'm not, I want to see if we could do the exchange where I'm a match for somebody and maybe their relative or someone is a match for her. I just knew I had to do it.
And I went upstairs. I didn't cry in front of her. I went upstairs. I called Georgetown because I had no one. I had no one. And I went upstairs. I called Georgetown. And I said, guess what? I said, my sister want to donate her kidney to me. And they said, really? I said, yeah, so what do I do? And they said, bring it in with you. I said, okay. And I cried, and I said, okay. And she came in with me, and the process went so fast.
Yeah.
It was amazing. It was amazing.
Rolanda, I love that you're wearing that bright green outfit to celebrate
To match my
organ donation.
donation
I
pin.
appreciate that. What was it like to go through the process of donating the kidney to your sister?
I knew I had to do it, so I wasn't worried about that. I was like, okay, I got 2. 1 is going to my sister. I didn't think I would be a match, and I was like, wow, I'm a match, you know, really? So I said, 1 is going to my sister, but going through the process and meeting with the different people and the psychologists and, you know, and I'm thinking, and then when they were explaining the risk and they were just so honest, and I was thinking, well, are they trying to talk me out of it? Because they were just really being honest, and they weren't sugarcoating anything. They were letting me know exactly what I was getting into. And I was like, okay, but I'm doing this. This is happening. This is her kidney. It belongs to her. And I was surprised it went so fast. I mean,
We started in
November?
We started, yeah, I think it was
November?
like October.
By January,
November.
kidney was
And okay, we came one day, you know, the evaluation, and they said, oh, can we test you now? Because she came with me. They tested her. This was on a Thursday. The Monday, she came to my house, and she said, stand up this time. I said, okay. She said, we a match. I said, oh my goodness. And then it was like around December, because honestly, I was failing everything. I was failing everything. And I said, I know I'm going to be the hold up. She said, don't worry, don't worry. In December, she called me. She said, Tina, they asked what date we want. We can pick any day. January. I said, are you serious? I was amazed. I was really amazed.
so we enjoyed the holidays together. In January, we had the surgery.
Yeah.
Well, you're both very courageous, and you both look fantastic here today.
Thank you.
If you would like to learn more about our Living Donor program or to become a kidney donor, you can call at 202-444-3700. We can now start taking your questions. You can ask a question by going to your computer screen or mobile phone, typing a question into the chat box and hitting send. Or if you're watching on Facebook, type your question in the comment section.
This is probably a good time for, while we're waiting for some questions, I wanted to just add that thank goodness you two were a match for each other and she was able to give directly to her sister. But one of the important messages that we want to get across today is that we have lots of people who this does not happen to, that they're not a match. Either we have people that are different blood types from each other, or they have a positive cross match because of the antibodies I was talking about before. And we really strongly want to get the message to everybody that even if this is the case, we strongly encourage you to come and get evaluated at Georgetown, because we have a lot of programs that hopefully can match people with appropriate donors. So like you mentioned a little bit, we have exchanges. So exchanges are where one donor can't give to their recipient, but we find another pair. And sometimes we do what's called a simple swap. It's just 2 pairs giving to each other. And sometimes we do what's a longer exchange. So we have 4 or 5 pairs, and it's kind of like a domino effect where everyone gives to each other. We also have procedures called desensitization, where patients undergo certain procedures that allow them to take the kidney from their original donor. So we'd like to tell everyone who might be listening that if they have had a donor that's been worked up in the past, and either at our center or at another center, and they've been told that it's impossible for this match to go on, we really strongly encourage them to contact us again and let us investigate a little bit. Let us evaluate if maybe that pair is possible for either an exchange or a swap or desensitization. Lots of things have developed. We've developed a lot of new procedures that make things possible now that might not have been possible in the past. So again, we strongly encourage anyone who might have a donor to contact us, and we can, reevaluate anything that's been done in the past.
I've been in organ transplantation for about 20 years, and I have to say that these sort of programs applied to kidney transplant only in the last 5 or so years have been extraordinary in making a difference in our ability to provide successful transplants to so many more people than used to be possible. So it's a very exciting time in kidney transplantation. I have a few questions from the audience, and I think I'm going to start with those. I'll start with you, Dr. Verbesey. Do I have to be a family member to donate a kidney to someone else?
Absolutely not. So most people, we have had, you name it, we've had it. We have family members, we have friends, we have fellow church members, synagogue members, and also we have some people who come forward as non-directed donors, meaning they don't have a specific recipient in mind. Once any donor comes forward, we evaluate them, we check their blood type, and we check what's called a cross-match. And for most people, to be honest, if they haven't been sensitized in some way in the past, they're not usually that difficult to match. So you definitely do not have to be a family member. We encourage anybody who wants to be a living donor to come forward.
I just add, and the outcomes are similar. I think that's the fear, is that I will have a less than optimum outcome if my donor is not related to me. And again, our data shows, and it's shown now for well over a decade, that the outcomes between related and non-related donors are similar. So as Dr. Verbesey mentioned, having that donor cleared from a medical and psychosocial standpoint is the key. The relationship, not so much, but it allows us to do so many potential opportunities with a living donor.
And I have two related questions here. Maybe Dr. Verbesey could answer them. First, how long is the surgery, and what is the recovery time for the donor?
So the surgery itself usually takes about 3 hours. I always add on time before and after as fudge factor, but usually about 3 hours, sometimes even less, sometimes a little more. And the recovery time, people recover very well. We do the surgery laparoscopically, which means with the video cameras. The incisions are relatively minor. Maybe Rolanda can tell us about hers. But and usually I tell people they're going to feel a little bloated, a little just kind of gross for a couple of days. But by a week, I find almost everyone feels much, much better. And by 2 weeks, nearly everyone feels almost back to baseline. So we tell people that it takes a few weeks after that maybe to feel some fatigue. But the recovery really, the vast majority of times, goes very smoothly. Do you want to comment about your recovery?
Yeah, the recovery was like 6 months before then. I had back surgery, so I had an incision in the front. And Dr. Verbesey was able to go into the same incision. And so it's like I had minimum scarring, and when I got home, it just, Dr. Verbesey was like, "Are you taking your pain medicine?" I was like, "I don't really need it, but I'll take a little bit," but I didn't need it really. It just went by. I was able to go back to Georgetown and visit my sister. So
wonderful. I have a couple more questions that came in from the audience. Someone was turned down at another transplant center because they were told their donor was not a match. Should they contact you?
Absolutely. So again, if you've ever had a donor that's been turned down anywhere else, or even by our center, because we've evolved as well. So if you've had a donor in the past that's been turned down, we strongly encourage you. Sometimes donors were turned down for reasons that we cannot overcome. However, there's a lot of reasons that donors were turned down in the past that we have new methods to deal with. So anyone who has a donor that's been evaluated in the past that would like for us to reevaluate the situation, then we strongly encourage them to contact us.
And again, sometimes it's as simple as making the phone call to that number that Dr. Fishbein mentioned, 202-444-3700. Ask for the living donor office, and we'll be happy to answer any questions. The biggest problem is, unfortunately, people are given bad or wrong information. So part of our responsibility is making sure that everyone gets the right information. So give us a phone call. We can answer the question, and it may be as simple as, we'd love to see again, or the reasons why perhaps you're not a compatible donor are these.
Rolanda, a special question came specifically for you. How much work did you miss when you went through the donation?
I think I was out about 2 weeks. That was it.
Very good.
I was out longer with the back surgery. It was about 2 weeks.
One of the things we should tell doctors, to make sure folks know, Dr. Fishbein, is the donor doesn't incur expenses for donating the gift of life. So the donor does not see a bill for their workup or their hospital stay or their surgery, which is very important because, again, we certainly wouldn't want to put a donor, really anybody who's given the gift of life through living donation, to have hardships after the donation. And so the bills are taken care of by the insurance.
For everything from the beginning to the end. My insurance paid for everything for her.
And if there are incidental costs, things like child care and even travel from a place to Georgetown, we have ways with which we can potentially help donors with those expenses also.
Someone else in the audience has asked if they have polycystic kidney disease and they have a transplant, can that disease come back in the new kidney?
That's a great question, because that certainly is, as opposed to some of the other causes of kidney failure, polycystic kidney disease is not something that is transmitted, say, through the bloodstream, that can actually be transmitted to the new transplanted organ. A related question is, sometimes people have such troubles with their polycystic kidneys that we can do a combined operation. If they have a living donor, we can take out their polycystic kidneys and do the living donor operation at the same time. It avoids 2 surgeries, 2 anesthetics, and is 1 recovery. But the answer to that question is polycystic kidneys, once removed or with transplant, the polycystic disease does not recur in the transplanted organ.
And Dr. Verbesey, a young woman is asking if she donates her kidney, can she still have children afterwards?
Definitely. So we've had many donors who have gone on to have families of their own. Our goal is that all our donors will go on and live totally normal lives after this. We don't want to limit them at all. So we've had many donors have children. We do tell young women to wait about 9 to 12 months after donating. You've got to let your other kidney have some time to recover, but after that they absolutely can start their own families. And we see, as part of we see all our donors at a week after transplant, 6 months, 1 year, and 2 years. We're religious about the follow-up of our donors. And so if any of these issues come up, people want to have babies, they have other health issues, then we certainly try to attend to anything that they need, because they're still part of our center.
Wonderful. Tina, somebody wants to know how you're feeling today.
Great. Wonderful.
We'll leave it at that. And do I have to be on medications for the rest of my life after the transplant? Want to tackle that?
Well, that's a very important question. The the immune system I always describe as one of the best designed systems in our body. It keeps us from being sick all the time. We want an immune system, but the medications referred to as immunosuppressive medications or anti-rejection medications they're very important after transplant. And so while the amount of medications, particularly the immunosuppressives, may go down and become either less in number or less in the amount of that medication, people do need to take them for the rest of their lives, because the organ, even years after the transplant, without those medications, could still reject. And so I tell people there's a choice. These are the choices to choose a life on dialysis, or to choose to take your meds once or twice a day and occasionally get your blood checked and make sure that everything looks okay. To those that have experienced both, most would tell you that answer is pretty easy, to take those meds occasionally and to make sure that getting lab work that once in a while we can assure that the organ is working well.
Good. Another question someone asks is, if I have a different blood type than my donor, can I still get a transplant? Maybe Dr. Verbesey, do you want to talk about very simple blood match swaps and
Sure.
how that's dealt with?
So by and large, the general wisdom is, yes, you have to be the same blood type as the donor and recipient pair. However, it's not totally true. What happens is, whatever blood type you are, you may have antibodies to other blood types. So there's A and B out there, like the 30-second primers, there's A and B. So if you're A, you have anti-B. If you're B, you may have anti-A. O's have anti-both. So so sometimes though we can measure the amount of antibodies there, and if it's very low, we can still find ways to give the person that kidney. So we do ABO, what's called ABO incompatible kidneys. Sometimes
So you remove the antibodies,
exactly,
and then you do the transplant, and then you stop them from forming new antibodies.
Exactly. So we do something called plasmapheresis, which washes the blood of the antibodies, and then we can sometimes still give that kidney.
And can we talk about a swap where people have different blood types? Let's say my brother wanted to donate a kidney to me, and he was the wrong blood type, and Rolanda wanted to donate to Tina, but she was the wrong blood type. How could that work?
So we have an entire pool of people that we're constantly updating, and we're always looking. If you guys came in but you weren't the same blood type, we're constantly comparing you to the new pairs that come in, just in case someone else comes in with a different blood type, but she matches you and she matches me, right?
So my brother could donate to Tina,
right,
and Rolanda could donate to me.
Exactly. So we're constantly comparing everybody in our system to all the new pairs that come in to see if we can do simple swaps.
And so if we did it that way, we do that all on the same day, right? All 4 people get surgery at the same time on the same day, and the kidneys go from one room to the opposite room, and we all go home in a week.
Exactly.
So that's one of the clever new sort of innovations in how we can offer transplants to people that nobody really had thought about, or it hadn't been worked out even only 5 years ago.
And I think to add to it, I think it's important to know that we not only are talking about pairs at our program, but we are the local repository for incompatible pairs amongst all of the transplant programs in the Washington metropolitan area, and we also participate in several national exchange programs, meaning we increase the number of pairs that are being looked at for our potential recipients. So the more opportunities, the more pairs, the better chances of finding that match for those recipients.
So you're saying possibly we could remove a kidney at Georgetown and send it across the country, and somebody across the country could take a kidney out same day and send it to us, and we could do the same kind of swap.
Exactly right. We no longer let time zones or state barriers or anything keep us from finding an answer through transplant. Now, especially electronically, we can do all those things, and it's pretty remarkable when we see what we're able to put together.
I have one last question from the audience that I'm going to go through, and then we're going to wind down. If I go on dialysis, am I no longer eligible for a transplant?
No, absolutely. We transplant people all the time that are on dialysis. We even have some patients who unfortunately maybe weren't referred to transplant, and they've been on dialysis for many, many years. But we'd love to catch people before that if we could, but certainly going from right before dialysis through when people are on dialysis, those are all people that are eligible for transplant. And
so most of the people on the list actually have already started dialysis?
Yes.
Well, as a reminder, this webcast has been recorded, so you can watch it again on the MedStar Georgetown website or on the Facebook page. If you have questions about transplant, here's the number again for our department, and you can call and get a live answer from somebody directly at 202-444-3700. I'd like to start by thanking Dr. Cooper and Dr. Verbesey, and most especially our guests, Tina McRae and Rolanda Franklin, for coming to be on the program with us today. And thank you all very much for tuning in and watching with us.